Good morning, everyone. It is my great pleasure and privilege to introduce Dr. Gerald Berry from Stanford University. We are so grateful that he graciously agreed to give this Zoom presentation in this unusual time. He actually visited us in early 90s and was looking forward to visit us again in person. I'm sure that we will find another time to invite Dr. Berry to visit us again soon. Dr. Berry grew up in Canada and got his Bachelor of Science and a Bachelor of Art degree from St. Francis Xavier University in Nova Scotia. After 4 years of medical school in University of Ottawa and 1 year of internship in internal medicine in Ottawa General Hospital, he moved to California and started his residency training in anatomical pathology in Stanford University. He continued his training in surgical pathology, transplant pathology, and immunopathology in Stanford University, and was appointed assistant professor in 1991. He rose through the rank to become a full professor in 2005. He has directed the cardiac pathology service in Stanford since 1994. He was a surgical path fellowship director from 2000 to 2016, the associate director and the co-director of surgical path in Stanford from 2004 to 2012. He is now director anatomical pathology in Stanford. Dr. Berry is a great teacher and a well-thought speaker. He volunteered his time with professional societies and serves as committee and program chairs. Dr. Berry has a long list of peer-reviewed publications and too many for me to count. His research is mainly focused on transplant pathology, pulmonary pathology, and cardiovascular pathology. He received the winning honors awards and a research grant. Today, he will talk about the mystery disease in giant cell arteritis and what we learn about the pathogenesis. Let's welcome Dr. Berry.
Thank you very much, Dr. Lee. I hope everybody can hear me. As Dr. Lee mentioned, I'm really looking forward to coming back and visiting. It's been a very long time. When I was just beginning as an assistant professor, there was a congenital heart session that was held at the university, and Jess Edwards from the Mayo Clinic was putting it on. It was for both pathologists and pediatric cardiologists and surgeons, and I very much fondly remember my time there, although it was short. It was in the summer, not the winter, so it was. I escaped to Canada in part because of the winter, so I do remember those cold, bitter winters. In any event, what I'd like to do today is to talk about giant cell arteritis, because I think it provides a very nice story and an overlap of the pathology and the pathogenesis. I've been very fortunate for the last probably almost 10 years now to work with two very distinguished and celebrated colleagues. This is Dr. Connie Wyand and Dr. Jorgi Goronzi, who run research labs and have a large slew of postdoctoral fellows who, of course, have done all the work that, and I'd like to present the work that they've done. I've had this opportunity to collaborate not only from the pathology side, but also in terms of identifying some of these pathogenic mechanisms. So what I'd like to do again is just start, as I like to do with most issues, is look at it from a clinical perspective briefly. We'll look at the pathology and the immunopathology and just briefly touch on sort of the differential diagnosis. Then we'll talk about the pathogenesis. As I mentioned, I think there's a nice overlap between the pathology and some of the different pathways. This is an extraordinarily complex disease, albeit it may look fairly straightforward on an H&E slide, but one of the things that we found is that it's like peeling an onion. Every time you peel back a layer, something new is there to be discovered. And I think that all these things, the work that is being done in Dr. Wyand's and Dr. Goronzi's lab, is sort of focused particularly on trying to transform a disease which at this point is treatable, so it's a controllable disease, but it yet is it remains incurable, and that the inflammatory infiltrate, as we'll see, often persists. A couple of clinical features. Giant cell arteritis is obviously an inflammatory vasculopathy. It has a predilection for the medium and large vessels. And this is a term that I'm starting to find more and more discomforting, as they refer to it as a disease of the elderly. Yet the guidelines for both the European and the North American rheumatologic societies sets that age at greater than 50 years. It's a disease whose signs and symptoms reflect a combination of both vascular insufficiency and usually systemic inflammation, and that in part is reflected in the acute phase reactants that we'll talk about briefly. In GCA, there's clearly an overlap in terms of the morphology with Takayasu's, things like aneurysm formation, dissection, rupture, and aortic insufficiency can be seen in both diseases. And we'll talk about some of the differences, because that's a disease now that we're turning our attention towards. In terms of the temporal arteritis, it's the classic manifestation of GCA, in part because it's a vessel that can be biopsied and studied. And then we're going to talk a little bit about polymyalgia rheumatica, PMR, because that's the extravascular manifestations of GCA, and that those typically manifest in the form of either muscle weakness, pain, or stiffness, often in the neck, shoulder, and the extremities and the pelvic girdle. It's interesting that the symptoms present often in the morning, so patients have trouble getting out of bed or brushing their teeth or putting a shirt on, and we'll look at those in a moment. So let's look first at the differences and the similarities between Takayasu's and giant cell arteritis. So Takayasu's is a disease of the, quote, young. That is to say, it manifests under the age of 40, often females in their late adolescent and young adult stages, presenting with pulseless disease, typically in the upper extremities. They may manifest with mesenteric insufficiency or ischemia, or even renal hypertension when those particular vessels are involved. GCA, on the other hand, as we've already alluded to, is a disease of older folks. Again, we'll see it has a predilection for females, perhaps not quite as high a ratio as with Takayasu's. These patients may present with blindness or aortic aneurysms, and as we mentioned, the PMR symptoms can be associated with it. In terms of the distribution of these diseases, there is some overlap and some differences. Obviously, the aorta is a prime target for both of these diseases, with Takayasu's involving not only the thoracic, but it can involve the abdominal, which is much, much less common in the setting of GCA. In terms of other arteries, there's an interesting distribution of the disease. So, for example, in the subclavian arteries, when it's involved in Takayasu's, it tends to be the proximal portion of those arteries, as opposed to GCA, when the subclavian arteries, it's more distal. Both may present with pulseless disorders, but the distribution of the lesions may be different. And as we've already mentioned, that the temporal artery and other branches of the carotid arteries, the ophthalmic artery and the vertebral arteries are not infrequently involved in GCA. Just one of the interesting differences, and this can be manifested, and we'll see that this is reflected in the histopathology, is that in Takayasu's, there's this very pronounced thickening of the adventitia, as demonstrated by the CT angio in a young woman who had tissue-proven Takayasu's, and involves, you can see here, not only the ascending aorta, but also the arch. And when you look at it from in the histopathology, you can see that these are taken at the same magnification, and really there's both intimal thickening in both. There's obviously medial damage and destruction in both. But if you look at the difference in the thickness of the adventitia, that seems to be the most reproducible and most pronounced changes. And Dylan Miller published a paper looking at those findings a number of years ago, a trichrome stain, again, highlighting the difference in this thickness of the adventitia between these two disorders. But otherwise, I find them to be very difficult to separate out without knowing the age of the patient. So giant cell arteritis, as mentioned, is a granulomatous vasculitis. Tends to affect females more commonly than males, and it's a disorder of folks over the age of 50. And it involves the aorta and its branches, usually the second through the fifth branches, classically presenting with aneurysm. And then in the branching vessels, it presents with stenosis or occlusion and the insufficiency associated with that. And it's often accompanied by constitutional symptoms. Here's a nice example of sort of the not infrequent scenario that we face with giant cell arteritis. So here was a 71-year-old woman who in 2011 underwent a repair of an aortic root aneurysm with an elephant trunk graft. And as you can see, the histopathology is sort of classic GCA with the intimal thickening, the inflammation and damage with the granulomatous pattern in the media. And she was treated with steroids and followed closely. And you can see within 2 years, there was massive dilatation of the descending aorta requiring a replacement of that portion of the artery. And again, the histopathology was fairly typical GCA. And it sort of brings up the concept that this is a smoldering disorder or an inflammatory process. There's finally then just some of the common clinical findings. And this is where it often requires the expertise of an experienced rheumatologist or an internist to sort out the sort of the likelihood that the symptoms are related to GCA. And for example, the headache can be is obviously a fairly nonspecific issue, but in the setting of GCA has a fairly particular, often posterior presentation. Scalp tenderness and jaw claudication are probably those three signs and symptoms are very important and should alert clinicians to the possibility of GCA in the appropriate clinical setting. Vision loss is obviously the most disconcerting and severe, one of the more severe complications, because once it's lost, it doesn't come back. It's often painless and sudden, and so it prompts the rapid investigation and often the temporal artery biopsy. And I think it behooves us to make sure that those specimens are processed both quickly and appropriately. And we've been through some of these other signs and symptoms already. The mainstay of therapy still remains corticosteroids, and for patients that don't have impending vision loss or vertebral basilar signs and symptoms, then it's oral prednisone, usually in doses in the 30 to 60 milligram per day range. And those are given until there's evidence of clinical and or laboratory response. And then I think it's important to that these patients begin to be tapered. We still see cases where patients have been on very high dose steroids for long periods of time without this tapering. And that, of course, has all its attendant complications, orthopedic and otherwise, with corticosteroids. For patients with vision loss, then of course an IV approach is mandatory. What's interesting about polymyalgia rheumatica, it's reported in about 40% of patients with giant cell arteritis. In some patients, it actually precedes the temporal artery symptoms or maybe concurrent with it, but not infrequently, it's sort of the first manifestation of relapse of symptomatology. Again, it's as part of the attempts to reduce the steroids, there's a great interest in using these steroid-sparing approaches. And this is just a table from a paper that came out a couple of years ago looking at some of the different biologics, as well as sort of the traditional drugs like methotrexate that have been used in various trials. And if you look at the outcome on the far right, you can see that many of these are unfortunately, are negative or inconclusive. Perhaps the most exciting drug that's currently in clinical use is this IL-6 inhibitor, tocilizumab, in a paper that Dr. Stone published in the New England Journal a couple of years ago, showed that by using it in the setting of a steroid taper, that they were able to reduce the the rate of clinical relapse, and that was as measured either by symptoms related to GCA or or polymyalgia rheumatica. But it also points out one of the interesting things that we're going to talk about in some detail is that it probably is focusing on just one arm of this multiple pathways of involvement. So one last thing is Dr. J.T. Lee, who was down the road from you for many years at the Mayo Clinic and then was out here at the University of California, Davis for a number of years, and I got to know him while he was out here. For residents and fellows, the reference is down at the bottom there, but I still find that book that he published way back in 1997, entitled Vasculitides, Biopsy Diagnosis and Rheumatic Diseases, I think is still probably the best book on vasculitis that's currently available. The pictures are in black and white, so you have to get used to that. But nonetheless, I think it's one of the more comprehensive and very useful books, and I have it out quite frequently. Anyways, he created what he called his 11 commandments of GCA, and some of them are fairly straightforward. Obviously, you should be biopsying the symptomatic temporal artery. Some of these patients will have tenderness over the temporal artery, and that would certainly be the one that's biopsied. But I think most importantly for clinicians is that the length of the biopsy is extraordinarily important. And in his book, he recommended a minimum of 2 to 3 centimeters. And that's in part, or in large part, because GCA is a focal segmental process. And thus a negative biopsy doesn't exclude the diagnosis. And I think the longer the segment that you have, the higher the likelihood of obtaining a diagnostic result. Obviously, the entire sample should be submitted for histopathologic examination. I've never found that frozen section have been very helpful, and we don't do them. The diagnosis of GCA really just requires inflammation and the presence and damage. The presence or absence of giant cells is neither here nor there, despite the name of giant cell arteritis, because as we'll see, they're only present in about 50% of cases. So you don't need giant cells to make the diagnosis. And if you require giant cells, you're going to miss the diagnosis. When present, they're often variable, and they're usually located near the internal elastic lamina. This is a case that I saw in consultation a few years ago, and it really brought home the concept of the focality of this process. As you know, there's 2 ways to process these. In the gross room, you can step section these vessels at 2-3 millimeter segments and submit them with a Voss tag. At least that's the way we do it. The other option, of course, is to put the vessel intact into a cassette, and then once it's processed and and hardened, then the histotech can cut through and do the step sectioning. At this particular lab, what they didn't do was either approach, and we basically have a coronal sections of the vessel, and this was about a 2-3 centimeter segment, the vast majority of which was entirely normal, except for this little focus right here, which is where the giant cell arteritis was present. So again, I think it exemplifies nicely the concept of focality. Already mentioned that about half the biopsies may not have giant cells. Another feature that people can sometimes get hung up on is the fraying or the fragmentation of the internal elastic membrane when you do an elastic stain. Recognizing that you can get reduplication and fragmentation as part of a normal aging vessel, the pattern then that you're looking for is this sort of non-uniform or non-segmental eccentric destruction in the setting of GCA. and compared to, say, a normal alterations. A final couple of notes. One is that steroid therapy given up to about 2 weeks before the biopsy probably doesn't do anything to change the histopathology. And so most of these patients, because of the fear of ocular injury, will often have started on their steroid therapy before the biopsy is performed, and that doesn't seem to affect the morphology. And again, if one does one's best in terms of evaluating the sample and having a decent sample to start with, the false negative rate should be quite low and under 5%. What I tend to do is up front we'll get 3 H&E stain slides with multiple ribbons on each slide, an elastic stain, and if it's negative, I routinely get a second set just to make sure that we're not going to fall into something in the deeper levels. Grossly, a well-developed GCA, the vessel is usually thickened, often sometimes bulbous and cord-like, and you can actually see the narrowing of the lumen grossly. Microscopically, it's a panarteritis, but the granulomatous component is the one that's most striking and is typically centered on or in the media. It's a mixture of inflammatory cells. Most of these, as we'll see, are T cells, macrophages, multinucleated giant cells. One can occasionally see variable numbers of eosinophils, mast cells, plasma cells, and very few B cells. If I start to see lots of eosinophils, then of course I'm going to start thinking about other disorders other than GCA. We've already mentioned that the giant cells are often localized in the media near the internal elastic lamina, and it's this asymmetric disruption that's very important in recognizing GCA. And you'll see that there's areas of alternating destruction versus preservation. Fibrinoid necrosis is very uncommon, at least in my experience. When it's present, it's usually near in the intima, near the internal elastic lamina, but it's often quite inconspicuous. And thrombosis, despite the abundant inflammation and remodeling that's going on, seems to be quite infrequent as well. Well, of course, this disorder goes back to Bayard Horton. It's also been referred to over the years as Horton's disease. This was first described back in the 30s. He thought it was perhaps related to an actinomyces infection. But I think this description from a sort of a review paper of his experience that he published in 1946 still actually has a lot of the information that we still see and use today. It refers to complete necrosis of the media and the media being replaced by granulomatous type of a lesion. In his experience, they were numerous giant cells. He thought that constituted the most frequent characteristic, that as we've also already mentioned, that the giant cells may in fact be absent. Well, here's what a typical aorta will look like in GCA. We have the H&E stain slide and the corresponding elastic stain. You can see the prominent thickening of the intima, the destruction and inflammation with the palisading inflammation around this necrotic media, and then variable amounts of inflammation in the adventitia. When you look at an elastic stain, it has this moth-eaten appearance of the elastic layer. And again, at high magnification, you can see the palisading histiocytes and other cell types. In this case, we've got multinucleated giant cells. In the temporal artery, which again, in about anywhere from 20 to 30% of patients with aortic involvement may have temporal artery involvement, and that may or may not be symptomatic. And the corollary is, of course, it's anywhere from 10 to 15%, maybe even higher, 20% of patients who have temporal arteritis will actually have involvement of the aorta. And so once the diagnosis is established, these patients are carefully evaluated with CT angios to make sure that the aorta is normal. But in the again, this low power magnification shows that this is a pan-arteritis with the intimal thickening. the inflammation in the media. This one also has some background calcifications, but you can also see even at this magnification how spotty or patchy the inflammatory component can be within the media. Here it is at higher magnification with that granulomatous appearance. You can see the multinucleated giant cells. Going back to the concept of the fragmentation, you can see that there's interruptions on this portion of the elastica, but it's completely lost in this right-hand side of the vessel. Nowadays, it's uncommon. We still have some of our surgeons that will do bilateral temporal artery biopsies. Generally, they'll just do the side that's symptomatic. But here was an interesting case of a patient. The right temporal artery shows rather classic-looking giant cell arteritis. But on the left temporal artery, and this was even with multiple levels, the only inflammatory component was in the adventitia, as demonstrated here. And so if I have a biopsy with just the adventitial inflammation, one step, of course, is to make sure that you level through it. Sometimes this will evolve into something more classic. But when you're left with just the adventitial inflammation, it brings up a differential diagnosis that includes things like a form first of GCA and other things. The immunophenotype, as we mentioned, is predominantly T cells, and these are CD4 in great numbers compared to the ratio with CD8. And this is in distinction to Takayasu's, where if you look at the aortas of Takayasu's, there are both CD4 and CD8 cells, but certainly the increased numbers of CD8 cells compared to GCA. In both disorders, of course, you're going to have huge numbers of macrophages. And as you can see, these macrophages are distributed throughout the various layers of the vessel wall. Just briefly, in terms of mimics, any of the systemic vasculitides, whether they be ANCA-associated or polyarteritis nodosa or Church-Strauss, they can, of course, involve the temporal arteries. And so, therefore, one needs to look carefully at the composition of the inflammation and to help distinguish some of these disorders. We have seen over the last couple of years 2 or 3 cases now of these patients that have low-grade, often lymphoplasmacytic lymphomas, where the temporal arteries, these patients are symptomatic, usually with headaches, and they'll be biopsied, and you'll see the lymphoma that's permeating through the vessel. One doesn't see the granulomatous features, but nonetheless, the inflammatory component, or at least the lymphoid infiltrates, can be quite striking. Other things that fall into the differential, I've not seen it, but in terms of cases, lesions that are listed, drug-induced hypersensitivity vasculitis. We do see, of course, the vasculitis of the vasovasorum that doesn't have the GCA components, and whether these are associated with rheumatoid arthritis or ankylosing spondylitis or other disorders, or whether they're isolated, needs to be evaluated clinically. And of course, amyloid can present with big thickened vessels. It's always important to keep in mind the possibility of a mycotic aneurysm. It's very uncommon, but nonetheless, it's always in the differential given the granulomatous component. This was a 72-year-old woman. She had previously had her ascending aorta repaired a number of years and was followed with surveillance CTs, at which point they identified an aortic arch aneurysm. She was asymptomatic, but it underwent repair because it was growing. And lo and behold, you can see that there's fragmentation and destruction of the media. There's tremendous intimal thickening, and there's abundant inflammation, including giant cells. But when you look at it at higher magnification, you can see that the predominant cell type, at least in the areas of necrosis, were neutrophils. And with an elastic stain, we identified the fungal fragments and these branching hyphae of Aspergillus. So again, although it's very uncommon, you still need to think about the possibility of infection. So with that background, let's turn to some of the current concepts of the pathogenesis of GCA. So the question becomes, what are the various pathways that are involved in taking a vessel that otherwise has this immune privilege and preventing the inflammation of the vessel wall, and turns it into this raging inflammatory mess that's associated with intense remodeling and intimal thickening, leaving these patients with little or no lumen, as demonstrated here. Well, some of the players that are involved in GCA involve both the innate and the adaptive immune system. In terms of the innate system, the vascular dendritic cells seem to be key players. They're located typically at the interface of the media and the adventitia, and have a number of roles to play. One seems to be sort of a gatekeeper role, but they also are able to express under certain circumstances, once they're primed, the CCL9 and 10, which are great chemokines for T cells. Macrophages are going to be distributed, as we'll see, throughout all three layers of the vessel, but they form sort of functional niches, as we'll see in a few moments. In terms of the adaptive system, the Th1 and Th17 are probably the predominant T cells that are involved, with the Th1 secreting interferon and gamma, and the Th17 secreting IL-17. There's other T cells that are involved, and we're sort of coming to identify them in time. IL-21 appears to have some role to play, and we'll look at that in more detail. If you look at the plasma of these patients, they have elevated IL-9 levels and other things. And one of the more recent T cells that seem to have an important role to play will be the tissue-resident memory cells. The vascular cells, both the endothelial cells and the smooth muscle cells, we'll go through and talk about in some detail as well. So one of the concepts that we think is important to recognize in GCA is that there are these very unique both tissue and immunologic niches in the different layers of the involved vessel. So, for example, these vascular dendritic cells, which have multiple roles to play, and as we'll see, seem to have an important role in the imbalance of the PD-1, PD-L1 checkpoint component. They're, as we've mentioned, are located in the adventitial layer. The T cells that are present in this region often secrete interferon gamma, IL-17, and IL-9. The macrophages seem to be rich in secretion of IL-6 and IL-1, and as we'll see, those are important in driving the various T cell components. When we look at the media, the macrophages that are present, whether they be typical macrophages or multinucleated giant cells, seem to have other secretory roles, including the secretion of growth factors such as VEGF, or platelet-derived growth factor. They also appear to be important in the secretion of aldose reductase, which seems to have some protective effect for some of these cells and some of the microenvironment. The T cells that are present in this region seem to be directed at the interferon gamma and IL-17. Moving on to talk about briefly the extravascular manifestation of PMR. This seems to be driven by an IL-6, IL-8 pathway with these pro-inflammatory cytokines that then will induce acute reactive phase proteins. And that results in the elevated C-reactive protein, etc. Most of these patients probably contributes also to some of the other systemic
they're really bad.
manifestations of this
layer
of this
porous,
disorder, things like the
take out
anemia,
all of
failure
the
to thrive,
organic matter,
and
then
fever.
plants can't survive it.
The question becomes, of course, is how important is that in the sort of the progression and sustainability of this disorder?
Just the extraction. The kit expired from
for example,
board.
it's been well shown that these acute reactive phase reactive proteins are imminently druggable, whether by corticosteroids or more recently by the IL-6 blockers. But the question becomes, how relevant are they for the pathogenesis? And that's basically
on Abbott?
the question: are they upstream or downstream of the vasculitis process?
Wow, interesting.
The pathways that have been identified so far in GCA, we've already mentioned some of them. The patient in a setting of a rich IL-12 environment,
the time it was expiring, the time it was
cells driven to the Th1 pathway,
it was not
expiring,
it was expiring
gamma,
after it was already.
Yeah,
it
was green when she put it on.
Vascular smooth muscle cell proliferation and endothelial cell activation, but these don't appear to be sensitive to corticosteroids. And this is one of the pathways that we think is important in terms of the progression and persistence of the disease. Whereas the environment rich in the IL-1, IL-6 drives it along the Th17 pathway. These are important in terms of responses to the various cell types. They're important for inflammatory cell recruitment and amplification of the process. But these, along with the IL-21 functions, and some of these are probably related to the follicular helper T cell. These are eminently responsive to corticosteroids. And it's interesting that the original studies that suggested that there may be differences in both these pathways and their responses goes back now to about 10 years. Dr. Deng, working in Dr. Wyann's lab at the Mayo Clinic, demonstrated that when you look at both circulating IL-17 producing Th17 cells, if you look at plasma IL-17, and if you look at tissue transcripts from the affected vessels, that in patients with GCA, there's no question they have elevated IL-17 and from these Th17 cells, and those were markedly diminished following the institution of corticosteroids. But in contrast, the interferon gamma producing Th1 cells seemed, as well as serum or at least plasma interferon, and looking again at the transcripts from the tissues themselves, those did not appear to have much of a response at all to steroids. And so this was the first one of the early signs that perhaps there's more going on here than just than just one pathway. This is a follow-up study that was done at the Mayo Clinic that was quite elegant and quite simple as well, and that involved identifying a group of patients who had signs and symptoms of temporal arteritis. They underwent a temporal artery biopsy, and you can see the surgeons there were quite aggressive, giving samples that were 3 to 4 centimeters in length. When the pathologic diagnosis was established, they were treated in the standard fashion with high-dose steroids. But interestingly, there was a group of the 40 patients who agreed to have biopsy of the contralateral artery, some at 3 months, others at 6, 9, or 12 months following the initial biopsy. And as Joe Maslewski demonstrated, there was persistence of inflammation, including the granulomatous type of inflammation, despite this standard aggressive therapy, indicating that immune privilege was not restored. A couple of tables from that paper. Again, these patients all had inflammation, most of it granulomatous and driven by lymphocytes and multinucleated giant cells and other cell types in the initial biopsy. But you can see that about 60% of the follow-up biopsies all continue to demonstrate demonstrate inflammation. The granulomatous inflammation seemed to be diminishing, at least with small numbers, but they seem to be diminishing over time. But nonetheless, the inflammation persisted both within the wall of the vessel as well as in the adventitial tissues and the perivasovassorum as well. So again, another clue that something else is going on here. And this led to this concept of tissue niches in the vessel wall. And I'm just going to sort of summarize these various pathways, and then we'll look at a couple of them in detail. So the adventitial layer, which of course is the gateway to this whole process, has a variety of different activities going on. MMP9 from monocytes appears to be important in inducing the digestion and destruction of both the internal and the external elastic lamina. And it also has a role in allowing T cells to infiltrate into the vessel wall proper. An important pathway appears to be the Notch pathway, and that the interaction of these Notch1 positive T cells with their ligand, which is Jagged1 on the endothelial cells, this seems to promote T cells, both production and secretion of things like interferon gamma and the IL-17. Another important cell that we've already alluded to is the vascular dendritic cell, and that in its interaction with the T cells seems to fuel this imbalance that with the deficiency of the PD-L1 ligand on these vascular dendritic cells, and that promotes T cell activation as well as survival within the vessels. The other component of this checkpoint system, of course, is CD68, and this also seems to have a role to play, as we'll talk about in a moment. In the medial layer, there's the interaction of the T cells, the macrophages, and the multinucleated giant cells. It's clearly going to result in loss of the vascular smooth muscle cells and matrix degradation. This is an extraordinarily complex process, but one of the things that we found is that MMP9 seems to again play an important role in this process. These matrikines that have been identified seem to have a pro-inflammatory function, and we're just beginning to try and understand that in some more detail. Here's an example of these multinucleated giant cells and histiocytes. This is with a nuclear macrophage marker PU.1, and the red stain is the MMP9, and you can see the abundance of MMP9 in these both multinucleated cells and these histiocytes. And this was right at the interface of the destroyed internal elastic membrane. And finally, in the intimal layer, there's this remodeling that results in luminal narrowing, is driven in large part by myofibroblasts, whether they're of endothelial cell origin or transformation and migration from the medial layer is still under investigation. Another important component in this, both in this layer and also obviously in the adventitial layer, is the neoangiogenesis that has an important role to play in sustaining this inflammatory process. And these all seem to be T cell dependent. One other thing to keep in mind is that while we've identified that the CD4 cells are the predominant cell type in this process, we also have to keep in mind that there's other T cells that may well have an important role to play. And this brings up the concept of immunosenescence, because as we've mentioned, this is a disorder of folks most commonly in their 70s and their 80s. And so Dr. Granzi and his lab looked at the makeup of these CD8 T regulatory cells, both in normal as well as in patients with GCA. These T regulatory cells have a very unique phenotype, and they're usually localized to the secondary lymphoid follicles. What they are able to do is express this NADPH oxidase 2 or NOX2 on their cell surface, but they seem to be particularly efficient at packaging this NOX2 into these exosomes or these microvesicles, which are then transformed and transferred onto these CD4 T cells, which then suppresses T cell activation and seems to have an important role in controlling the actual size of the T cell compartment. And what it was able to demonstrate is that in patients that don't have GCA, there's both a functional and to a lesser degree a numeric decline in the numbers and efficiency of these CD8 regulatory T cells, and this is exacerbated in the setting of GCA. We'll look at that in a moment. So here's just a schematic of what these T cell regulatory cells are thought to do, and that's, as I mentioned, the packaging and creating these exosomes, which then will have a very efficient mechanism in controlling the size of the CD4 population. So this is a study that's part of the paper that showed that in young patients, and this was, I think, under the age of 30, that the percentage of expression of this NOX2 on these T regulatory cells is quite high compared to older patients, and these were otherwise healthy adults over the age of 60. And that's in comparison to patients who had other rheumatologic diseases with psoriatic arthritis, both younger and older patients, sort of mirroring the pattern that you see in the normal situation, and patients with small vessel vasculitis. But if you compare in the central part of this graph, patients either treated or untreated with GCA, you can see that there's already a reduction in this NOX2 expression. What they did is then took an NGS or SCID mouse and reconstituted it with human CD4, and then used various combinations of other cell types to look to see what the T cell population was doing. So after reconstituting them, they waited 9 or 10 days and then sacrificed the animals and then looked at their spleens and did these CD4 counts by flow cytometry. You can see if you just add the CD4 cells without any CD8 cells, there was really no limitation on the T cell population. The same pattern was seen if you added just CD8 cells. But if you added the CD4 cells along with the CD8 T regulatory cells, there was a marked reduction in the size of the CD4 population. And then other ways to look at that, of course, is to look at actual numbers, and you can see the same distribution is demonstrated by flow cytometry, and you can also look at the division index or proliferation index and see the same thing. What they then did is they took these CD4 cells along with these are CD8 T regulatory cells from older patients, and so it's listed as old CD8, but these are regulatory CD8 T regulatory cells from older healthy patients, and when they added those in this model, you can see there was very little change in the population. But then, if they used a NOX2 vector that they added to the mix, you could see a marked suppression of the T cell population. And again, that could be expressed either as the percentage of T cells or actual numbers. And this was also reflected in both the division index and the proliferation index. So this forced overexpression of NOX2 seems to rescue the suppressive activity of these T regulatory cells, and that's yet another component of this process. So we've already alluded to the niches that are present, the tissue niches, and their various cell components. So now let's look at them now in a little more detail. So one of the first areas that we investigated a number of years ago was this Notch pathway. This Notch signaling pathway has an important role to play in both regulating T cell differentiation and also in the development and activation and function of these vascular endothelial cells. So adventitial microvascular endothelial cells have this immunoregulatory function by upregulating the expression of the ligand, which is Jagged1 on the endothelial cells. And this all seems to be driven in large part by VEGF. Patients that have GCA seem to have markedly elevated levels of VEGF. And as my colleagues have said, the vessels are often swimming in VEGF. And it induces this Jagged1 expression, which then allows the endothelial cells to regulate the T cell function in a sort of cell-to-cell crosstalk. If you look at gene expression studies in the tissues, you can see that there's clearly a marked elevation of gene expression of both the Jagged1 on the endothelial cells as well as Notch1 on the T cells. Another way to look at it is by immunohistochemistry. This was a negative or a control sample where you don't see the Jagged1 expression. And whether you're looking at a temporal artery or an aorta in patients with GCA, you can see this marked increase in Jagged1 expression. And it's hard to see it on this, but these are located primarily in the adventitial regions of the vessel. Another way to do it is to create this human mouse chimera using an NSG mouse where you place a segment of normal artery, human artery, it's usually an axillary artery, and then at day 7, you do adoptively transfer peripheral blood mononuclear cells into the animal, and then one can treat them with various inhibitory or stimulatory drugs, and then 2 weeks later harvest the animals and look at the effect on the vessel itself. And so in this particular study, we looked at using either increased doses of VEGF or an inhibitor of the receptor signaling for VEGF. So with VEGF alone, you can see that again when we do this immunohistochemical staining, you can see a marked increase in the number of Jagged1 positive cells on these endothelial cells, as well as an increase in the overall numbers of these activated Notch1 T cells, as demonstrated by the CD3. This is also demonstrated by other mechanisms, and so this was the normal. Not the normal, but this is the vasculitic lesion that we can generate through this chimeric model. And then when you add VEGF, you can see that there's a marked increase in both the expression of Jagged1 cells as well as the Notch1 T cells, and that's going to be inhibited when you use this axitinib, which is the VEGF inhibitor. This is sort of exemplified in this image. So the untreated animals will have the vasculitic development as part of the typical pattern that we see in these chimeras. When you add the VEGF, you can see a marked increase in the number of T cells, and then when you add the inhibitor, markedly diminished. And when you look at the expression again across both Jagged1 and Notch1, as well as T cells and macrophage gene expression. Another component of GCA is this imbalance between PD1 and PDL1. Everybody who's seen lectures on various cancers, including lung cancers these days, will be very familiar with this image. The co-stimulatory and co-inhibitory components of of these various pathways. There's the CD28, CD80, CD86 pathway, which is a co-stimulatory direction, and the inhibitory association between PD-L1 on the antigen presenting cell, which in the case of GCA is the vascular dendritic cell, and the PD-1 that's on the T cells. And one of the things that we were able to demonstrate is that if you look at normal aortas or normal arteries, you're going to see a fairly high expression of this PD-L1, but this is markedly reduced in patients with GCA. And the corollary of that, of course, is that the PD-1 receptor is going to be quite low in patients that have normal aortas or normal arteries, but markedly elevated in patients with GCA. What we were able to demonstrate is that that the dendritic cells are there. It's not as a result of an absence of these dendritic cells, but they just seem to not be able to express the PD-L1 on the cell surface. And the resultant feature of that, of course, is that there's a marked activation of these T cells. And this is expressed in a variety of ways. I'll just go through this quickly for the lack of, we don't have a lot of time, but when you stimulate these cells, you can, under normal circumstances, you can see a marked increase in PD-L1 expression, but that is markedly muted in these GCA patients. Again, we can use this human mouse chimeric model where, again, with adaptive transfer of the peripheral blood mononuclear cells. And in this case, we're going to manipulate it by daily injections of a PD-1 blocker. And the result of that is we're going to go from the sort of the typical pattern of vasculitis and lots of T cells that are present to an overabundance of T cells when we add this PD-1 blocker. And that is also expressed in this gene expression with transcripts for the various macrophage markers, as well as activation markers of T cells and other components. It also seems to play a role in intimal hyperplasia, which again is part and parcel of this disease process. That when you add this PD-1 blocker, it seems to exaggerate not only the inflammatory component, but there was an increase in the intimal thickness in the retrieved vessels. And then finally, it also seems to play a role in the microvascular angiogenesis. When you double label with von Willebrand factor and a smooth muscle actin, you can see under normal circumstances just an occasional vessel. But when you add the PD-1 blocker, there's a marked increase in the number of vessels, and those can be measured by looking at vessels per high power field. One other thing then is the role of CD8. We mentioned that both components of this checkpoint pathway seem to be involved. I'll just briefly mention that that this seems to play a role through glucose utilization in the T cells. But what it appears to be particularly helpful in doing is promoting these vasculitis-inducing T cells secreting interferon gamma, and it allows differentiation into these resident tissue resident memory T cells, which seem to be important for replenishment of the tissue infiltrates, and then persistence and longevity and intensity of the inflammatory infiltrate. And I'll just go through those. I won't have time to go through those in any detail, but let me just finish then with the concept of are there some potential markers based on some signaling pathways that are on the horizon that may actually be very useful in the suppression of this vasculitic response? The kinase, as well as the STAT signaling pathway, seem to play an important role in the T cell biology, particularly the Th1 lineage commitment seems to be related to STAT1, to a lesser extent to STAT4, and the Th17 regulation seems to involve STAT3. It's been shown that there's a number of these polymorphisms can be linked to other autoimmune disorders such as rheumatoid arthritis, systemic sclerosis, and lupus. In fact, these JAK inhibitors, this tofacitinib, is used now routinely in patients with rheumatoid arthritis. Excuse me. So we asked the question, could it potentially have a role to play in giant cell arteritis? And when you do these heat maps and look at transcript expressions, you can see that in the GCA arteries, there's an abundance of the STAT1 and perhaps to a lesser extent the STAT2 expression, and the same thing when you look at the transcript expressions. When we go back to our animal model, this tofacitinib is very effective in reducing not only the number of T cells, but both within the tissues, but also macrophages, and that seemed to be in part related to its ability to diminish these resident memory T cells that are CD4, CD108 expressing cells. It also played a role in reducing the intimal thickness as demonstrated in the control versus the treated animal. So this is one drug that seems to be have a potential application, and we're continuing to explore that. So in summary then, GCA is a disease of the medium and large size vessels that's currently treatable, but I think is incurable. There's a complex and innumerable numbers of pathways, some of which will respond differently to corticosteroids. And some of the important mechanisms seem to be an imbalance in this PD-1, PD-L1 immune checkpoint, and the loss of the gatekeeper function of the microvasculature. And these seem to be two very central components in this inflammatory barrage that takes place in the vessels. And I think that ultimately these new therapies are going to be driven by continual new insights into the pathophysiology. So in summary, I think this is a nice disease to study both the pathology and to see how the pathophysiology fits into the process. And with that, I thank you for your attention and be happy to answer any questions. Thank you.
Thanks, Dr. Berry, for this interesting talk. I think we can ask some questions. When you ask questions, please unmute yourself. Anyone have questions? Just curious about the inflammatory cells. When you don't see the typical pathological change, do you do like CD68 or other T and B cell markers to demonstrate this inflammation? In some biopsy, you don't see that much information unless based on histology.
I usually just go by the histology, and if there's something that looks askew, then I'll first start with levels, just to see if we can fall into something that's more definitive or more characteristic. And then on occasion, I've done inflammatory cells, but it's always a question of what happens if you see one or two T cells or one macrophage.
Yeah.
So I really like to see the structural disruption. The issue, of course, becomes when you see a distorted vessel that's not clearly just that sort of intimal concentric arteriosclerosis that you get with aging, but rather that you do see some alterations in the media, and that with the EBG stain, that may bring up the idea that this is a healed vasculitis. So there's all kinds of components, and then of course it becomes important to do the clinical pathologic correlation. I should mention that this is on the clinical side, it's not just the rheumatologist, but we have a whole host of folks that are part of the vasculitis clinic that includes cardiologists and surgeons, cardiac surgeons, neurosurgeons, ophthalmologists, and plastic surgeons, as well as our thoracic radiologists. So it's an extraordinarily active group that, and these patients are so complex that it involves multiple disciplinaries to try and understand and manage them.
Thank you. Anyone have questions? If not, I will thank Dr. Berry for this wonderful talk, and hopefully we can see him sometimes in the near future.
All right. Thank you so much for having me.
Thank you.
Take care. Bye.
Bye.